ladies and gentlemen, distinguished guests and speakers. I know you must be very hungry now. I try to make it short and sweet. Okay, so it is an honor to be here today, Dr. Sondari, the very first National Cancer Congress Malaysia. Congratulations. Actually, I have been asked by the Honorable Director General to present this talk. It is entitled Transforming Health Systems for Cancer Care, the Malaysian Perspective. I would like to make a disclaimer. I am a clinical oncologist by training, so I'm not a public health physician, and I must admit that I'm not the expert, so please don't ask questions. Okay, can we move on to the next slide? So cancer is one of the most important and prevalent NCD worldwide and also in Malaysia, and the incidence is expected to continue to rise. It is the second most common premature death after cardiovascular diseases. The SDG target 3.4 is to reduce premature mortality from NCD by a third by the year 2030, relative to 2015 levels, through prevention and treatment and promote mental health and well-being. Next slide. Before we can transform cancer care system, we need to first understand the determinants of cancer and the global ecosystem as they are interrelated. There are modifiable and non-modifiable risk factors. Majority of cancers, be it globally or in Malaysia, are linked to modifiable risk factors. Tobacco use remains the leading cause responsible for 1 in 5 cancers globally and 1 in 4 cancer-related deaths. Other significant factors include infections such as the hepatitis B, C, EBV, and also HPV, and unhealthy diets, physical inactivity, and also obesity. Only 5 to 10% of all cancers are attributed to genetic factors which are non-modifiable. Next slide, please. So Malaysian faces a high burden of NCDs with millions of adults from conditions like diabetes, hypertension, hypercholesterolemia, and obesity. These conditions significantly increase the risk of cancer and complicate the cancer management itself. Although on the graph, you can see that there is a reduction in the prevalence of NCDs, but we have not reached the target for 2025. Next slide, please. So Malaysian National Cancer Registry was started in 2007 to capture cancer burden in Malaysia and was reported every 5 years. These graphs describe the annual trend of total cancer cases in Malaysia from 2007 to 2021. Also highlighted the year when the online notifications began and the year when the formal directive for online cancer registration was issued. We believe that these two events lead to increase in cancer case reportings for 2017 to 2021. The overall of new cancer cases in 2017 to 2021 was increased by 46.5%. Next slide, please. So consistently since 2007, female gender had a greater incidence of cancer compared to males. For the data 2017 to 2021, the incidence rates of female is 121 per 100,000 females versus 107 per 100,000 males diagnosed between 2017 and 2021, and this shows a very marked increase. And the graph is expected to rise due to increase in population, increase in aging population, and also increase in the burden of NCDs. You can also appreciate that the increase in incidence has also raised the lifetime risk for both genders. Now the lifetime risk stands at 1 to 8 for both genders. If you can remember that the previous registry, the incidence or the lifetime risk for male was 1 in 10, and in females, 1 in 9. Next slide, please. So based on the recent database, the 5 major malignancies, breast, colorectal, lung, lymphoma, and liver accounts for 52.8% of all cancer cases. The cumulative of the 10 most common cancers account for 2/3 of all cancers in Malaysia. Colorectal and lung cancers affect both male and female genders. Liver cancer was previously at the 8th position, now has moved up to the 5th place. And most of the cases, most of the liver cases are due to metabolic disease. Not longer associated with viral hepatitis. This may reach the precancerous lesions. We also have started vaccinating girls at the age of 13 since 2010. I think it's too early to see the effect of vaccination in 2021. So next. So upon cancer notification, the chat needs to be reported at the variables. In percentage of state formation from 53% to 42%. As the thing on how notification by any administrative process. In general, 65% of the cancer cases, and especially lung and liver cancers, have high percentage of cases diagnosed at late stages. Next slide. So in response to increasing burden of global cancer, WHO has come up with several focused initiatives and strategies to bringing multiple stakeholders from around the world and across the sectors with the objective to reduce the cancer burden. So I think most of you are familiar with this initiative. I don't think I would talk long on that. Okay, we move to the next slide. Next slide. So MOH recognizes the need for a national strategic plan to improve cancer control long time ago. I think it started in 2006. The strategies to address cancer burden must be tailored to the local context, and it must take account for the country's most prevalent cancer type and tackled according to the country's available resources. The first published document was the National Cancer Blueprint 2008-2015, aimed to reduce the negative impact of cancer by decreasing mortality and morbidity, and also improve quality of life of cancer patients. Third publication, National Strategic Plan for Cancer Control Program 2021 to 2025, with the overall target by 2030 to downstage breast, colorectal, and cervical cancer at the time of diagnosis by 25%, to improve 5-year relative survival for colorectal, breast, and cervical cancer, and to reduce the risk of premature mortality rate caused by cancer by 1/3. Next slide. The NSP-CCP also supported by documents which are more focused and with specific approach. For example, the National Strategic Plan for Colorectal Cancer, which produced together with NSP-CCP, because we know that there are huge gaps in the colorectal cancer. We are detecting patients at the advanced stage. Many strategies and has been outlined in that document. Apart from that, we also have the action plan towards the elimination of cervical cancer in Malaysia, which in line with the WHO movement. We also have the national guidelines for early detection for breast cancer, which we have started since 2011. And National Palliative Care Policy and Strategic Plan 2019-2020. Next. So MOH also adopts WHO best advice for primary prevention to address NCD, including cancers such as reduced tobacco use, reduced prevalence of alcohol, reduced consumption of the unhealthy diets, and reduced prevalence of overweight, obesity, reduced exposure to carcinogens, and implementation of national immunization for Hep B and HPV. These best advice are incorporated in several national health policies and also in the regulatory acts. Thanks. The strategic framework for cancer control program aims to reduce premature death due to cancer. The output indicators measured include incidence, coverage, accessibility, and survival. MOH cannot achieve this goal It requires whole government and whole society approach. We have to partners with private, academia, NGO, and community. The technical committee and technical expert working group determine the governance and policy contact. And the policy contact must align with the health white paper, with the National Strategic Plan for NCD and other national strategic plans. Next. The key transformation in cancer control is the strategic planning of a strategic partnership with the non-government organizations and also healthcare facilities. During the World Cancer Day recently, 23 cancer NGOs had committed and pledged to close the cancer gap. An action plan is work in progress to inculcate the role of NGOs in supportive care framework for cancer, and the scope for this action plan follows the focus areas of NSP CCP 2021-2025. Next slide. These colorful slides alluded the NGO supportive care framework in the continuum of cancer care, from prevention and health promotion to screening and early diagnosis, treatment, recovery, and research. The delivery of integrated cancer care involves multidisciplinary teams such as paramedics, family medicine specialists, physicians, oncologists, allied health, and research institutes. Next. So MOH could not work alone. Cancer is everyone's business. And the areas for cancer NGOs to work together with MOH in closing the gap are marked in the orange boxes. First, screening for lung, liver, prostate, and nasopharyngeal cancer. Number 2, training on screening modules for general practitioners. Number 3, community empowerment on cancer screening literacy and cancer navigation. NGOs also involved in the research works and survivorship care and palliative care. There has been existing collaboration of other stakeholders, such as the public-private partnership, in supporting public center delivering treatment, such as surgery, radiotherapy, and systemic therapy. MOH also partners with public and private universities in doing research based on research activity priorities, and at the same time support implementation and reduce the research gap. MOH also partners with Malaysia Hospice and Palliative Care Council in providing survivorship support and palliative care. Next slide. So this is our way forward in cancer control program in Malaysia. It follows the strategic framework. The framework is to show how it works with collaboration from multiple stakeholders and align with the Pillar 1 and Pillar 2 of the Health White Paper. Okay, next slide. In transforming health system for cancer by closing the gaps in the cancer care continuum, MOH cannot work alone. We need to strengthen collaboration with other partners, private, NGOs, academia, and community. Community, we need to empower them on cancer screening literacy and navigation. And last but not least, we also need to enhance capacity, integrate digital health, and artificial intelligence in cancer control program. Okay, next. So this is my final slides. I would like to thank Dr. Ilyana Ahmad for helping me preparing the slides. Thank you.
Thank you very much, Dr. Rose. Are there any burning questions from the floor? We have time for one or two. Zooming hands up.
Yes.
Was there one? Yes. So may I ask that you kindly introduce yourself and also your primary affiliation before your question?
Thank you, Dr. Geeta Sanway.
Hi.
Hi. Just quick curiosity on our strategic plans. If we have statistics on how far are we from those visions, because we have the 2030 goals, right, for the plans. So just want to understand, are we like near or far from those goals that we have set out in our plans as a fellow Malaysian here?
Well, I think the best person to answer is the public health physician. But I guess that there has not been any published analysis on whether we have reached or not. Currently we are at the 2021 to 2035 national strategy plan. So normally it will be evaluated by the end of the period.
So I have a quick.
Hi.
Hello,
Hi.
thank you so much for the presentation. I'm Dr. Hadi, Scientific Advisor of Qatar Cancer Society. I really love the mapping of the integration of the NGO and the cancer care continuum, how they are involved with the MOPH. But I have a question. I mean, I think this is a challenge that we are all facing. What's the integration and data sharing between NGOs and Ministry of Health regarding cancer patients? I mean, us in Qatar, as His Excellency Dr. Khalid mentioned, we are sharing our data that we have. We collect a lot of data at the socio-economical level of the cancer patient, and we share it with the cancer registry. But is there this streamlined sharing of data between the NGOs and MOPH, or Ministry of Health, sorry, we call it in Qatar MOPH, Ministry of Health in Malaysia, regarding cancer patient?
Okay. I think, okay, someone who wants to help answer the question? Dr. Ariana. Dr. Ariana is here she's a public health physician.
Testing.
Thank you, Dr. Rose. Okay, I would like to answer the questions on the roadmap on the integrations with the NGO. For your information, this is the initial planning stage only, because at the moment we yet to share any information between the NGOs and the Ministry of Health. So the framework is actually based on our National Cancer Day, I think 2 months ago. So where we met, the first time we met all the NGOs that involved in cancer program, and then we map out whether they are actually doing awareness, they are actually assisting patients for the financial aids and so on, and then when they are helping the professional bodies as well. So that's why we came out with the roadmap, and we hope that this roadmap or this framework will be the next of our plan for cancer program. And of course, we are in the view of trying to merge the data, the information based on this framework. Thank you.
Right, thank you. Surely with all the great work that all the NGOs are doing, using the data that they generate will be a huge opportunity. So thank you very much, Dr. Rose, and I would like to invite Dr. Santari to present Dr. Rose with a token of appreciation. That brings us to the end of this morning's keynotes. I will now pass the time back to Ms. Mahira.